It's a real pleasure to be here with you while the slides are coming up. I think this is great, and I relish the opportunity to get to be involved with families in this setting. Pregnancy care is one of the maybe most interesting questions that not just young women have with congenital heart disease, but young men as well, and maybe one of the most anxiety provoking. And it's certainly, if you go out in the community, it may provoke anxiety in your other care providers. So we're going to talk a little bit about what it means to have a healthy mom and hopefully a healthy baby if you have adult congenital heart disease. So the common questions that I think most patients who come into or hopefully prenatal counseling have is first, can I become pregnant? And I really take that question literally, not as a question, may I become pregnant? Because I'm not the gatekeeper of that question, and none of us should be in your care team. We should be your advisors about risk to you and to your baby with pregnancy, but none of us are here to give you the hall pass, yes, no, pregnancy. That's a personal decision. So if the question is, can I become pregnant? That means physically, can I conceive a child? And we'll talk about that. Most importantly, what are the risks of pregnancy to me? Could I die from pregnancy? Could my heart get worse? What could happen to my baby? Could my baby die or be born early? Do I have to have a C-section? I would think that's the most common question that I get in terms of the actual process of delivery. What are the chances that my baby will have my defect or another type of heart disease? And does this change my long-term outlook if I complete a pregnancy? And I think these are all super important questions, and some of them we know the answers to, and others we don't quite know. So let's just start first with the actual can I become pregnant, meaning can I conceive a baby? And the answer is almost all women with congenital heart disease can conceive. So the answer is yes to that, with a few exceptions. If you're chronically blue, your oxygen saturation is low, that does alter your fertility. It doesn't mean you can't conceive a baby, but you're going to have lower fertility rates, and then you are going to have some special problems during pregnancy in terms of maintaining the pregnancy that we'll talk about. If you have Turner syndrome, you often don't have ovaries that work, so you may have dealt with your coarctation and your bicuspid valve, but you may not be able to conceive without special fertility treatments if you have your uterus intact. And then of the other group, there's a complicated syndrome. It goes by a lot of different names, but some of my moms with congenital heart defects have this, and they don't have intact uteruses, and so they can not conceive naturally either. So for the most part, this is a pretty small list. Most of you guys can conceive. So the real question is, what is the risk of conceiving to me? Should I become pregnant? Not can I become pregnant? And what does that mean for me? So what are we going to ask when you come in for counseling? What are we going to know or try to put together to help give you an estimate of risk to your health? Well, first we want to know, what is your current heart function? What's the status? And that may entail several tests, usually an echo. We love echo, as Dr. Cedar said. You know, you guys get them all the time. We may want to do MRI to get a little bit better estimate of heart size or function in certain situations. Some patients may benefit from a CAT scan if we're looking at your aorta and we want to look at a certain dimension. We can do that with MRI or CT. And sometimes we might want a cardiac catheterization. Maybe we need to measure the pressures, or maybe we need to clarify something to truly understand your risk. Well, then I want to know, what is your current exercise capacity? Because this is a marathon pregnancy. What a stress test. It's going to last for 9 months. So I need to know, what can you do on a day-to-day basis? And that matters. So a patient with tetralogy who can't walk 2 blocks without stopping is a different patient that I counsel with tetralogy who's running marathons. So it matters what your exercise capacity is. And I may put you on a treadmill, or your physician may put you on a treadmill and actually measure it, because sometimes we don't really know what our exercise capacity is. We go, well, it's pretty good. So we might want to put you on a treadmill and really see, and that can help us look at your risk. What medications do you take to maintain your heart function, or what do you need because of heart rhythm problems? Those are going to play a role in your risk of pregnancy to you and to your baby. And some medications are going to be kind of a no-go for pregnancy. Some we're going to continue and try to talk about the risk of continuing that medication. And then really importantly, what struggles have you had before? Did you have a repair and you've been doing really well and you've never really had a complication like a stroke or a mini stroke, what we call a TIA? You've never had to be treated for heart failure where your heart was not beating efficiently enough, where you maybe needed Lasix or other diuretic drugs? Did you have a rhythm problem from the top or bottom chamber of the heart that needed treated? All of those are important. And then pragmatically, have you had another pregnancy and how did you do with that? That's really important to me. I've had women referred to me for, oh, it's going to be so bad that she's got this condition and now she's pregnant, and you find out she delivered a healthy baby 9 months ago and never had a symptom during pregnancy. Well, she already passed the stress test. That's important to know. So we're going to ask all these things and try to help you understand risk, because the changes that occur to your heart and vascular system during pregnancy are tremendous. This is one of the most fascinating things of physiology to me, what the body can do. So starting right after conception, we're going to start increasing the amount of fluid in the blood vessels. So your overall blood volume, both the kind of liquid component and the blood cell component, is going to go up. So you're going to have a lot more fluid in the tank, is what I tell the patients. The number of red cells are going to increase, so you're going to try to get some more oxygen carrying capacity, but it might not keep up with the fluid in the tank. So you could be a little anemic during pregnancy. And then we're going to ask the heart to actually deliver a lot more blood each time that it pumps so that we can maintain and grow another human being. And so there's a lot of interesting things that are happening, and we need to know if your heart condition can cope with these changes in blood volume and demands on the heart. So that's going to be important. So this is an old risk stratification classification. It's now been around for well more than a decade, but it's very, very helpful, I find, in talking to patients, because it's kind of straightforward and it kind of makes sense. You just can wrap your head around it. There are 4 predictors of cardiac risk of a complication during your pregnancy. If you look at this risk model, this was a large group of women, not just with congenital heart disease, but other heart defects that were studied to come up with this. And so this is not, I emphasize, a risk of dying during pregnancy. In all of the studies, the risk of dying is actually very, very small from pregnancy. This is a risk of having a heart problem, like I need medication, I might need bed rest, I might need a hospitalization, I might have a rhythm problem. That's the kind of risk that we're talking about. And so we want to know, did you have a prior episode of heart failure or a heart rhythm event? That gives you a risk point. And if you had, you're not doing too well, you're a little blue, your room air saturation's less than 92%, or if you really can't keep up with your activities of daily living without some limitation of shortness of breath or swelling, that's going to give you another point. In this initial group, they looked really at the left heart. You guys know that we're really into the right heart and congenital heart disease often, but left heart obstruction came out in this group because those people couldn't increase the demands, and so having a valve problem that didn't let you put out more blood flow was a risk factor, and in your left heart if it didn't pump efficiently or squeeze efficiently. And so you just add up the numbers. If you have no risk factors, your risk of a cardiac complication during pregnancy was almost that of the general population. But if you got just one of these predictors, you went up to about 25% chance that you would need some sort of medical intervention during pregnancy. And greater than one, it became more than 2/3 of women had an issue. So this is kind of helpful to talk about. I think it makes sense to the patients, and we can really talk together. Well, there's other risk classifications, and we've tried to make this a little more streamlined to focus on congenital heart disease. The World Health Organization did come out with a risk classification scheme and tried to give us some idea of, if you're in a certain risk class, how often do you need to see a cardiologist during pregnancy? What do we think about your risk of dying or having a complication? And you can see that the higher your risk class, the more often you're going to need to see a cardiologist, the more we think your risk is increased. Well, that sounds good, but you need to know what risk class do you fall into? And just to give you some examples, class 1, that kind of lower risk but should see a cardiologist a couple times, would be like a repaired ASD, a repaired VSD. Class 2, that little higher risk, your ASD is unrepaired, or you have a tiny VSD that's not thought to need surgery. And then class 3, if you have valvular heart disease like pulmonary stenosis or moderate aortic stenosis. And then class 4 gets into these patients that we really need to be careful with our counseling and be very thoughtful. Patients who have really tight aortic valve, really tight mitral valve, or as Dr. Cedars talked about, the patient with Eisenmenger syndrome, that's where your blood vessels in your lungs are really restricted to blood flow and your lung pressures are really high. That's a really serious thing to face during pregnancy. There's some other models here. We don't have to go into all the details, but this is from a large group in Europe. This was just congenital heart disease women, so this was helpful. And they gave different points for risk factors, so kind of like that first easy scheme, but maybe a little more difficult. I just want to draw your attention to look at what the highest risk predictor was. Having a mechanical heart valve puts you in a pretty high risk of a cardiac complication. And so while we can think your valve functions normally, that can be a really big deal for you to deal with during pregnancy. And then even just taking medications for your heart increases your risk. So this I think risk stratification scheme is also helpful when we're talking in the office. So if you came to me or one of my colleagues for pregnancy counseling, who would I say, we may not be the best idea for you to have a baby because of the risk to your health, and that would be moms with pulmonary hypertension. And I would consider that if your blood pressure in your lungs is more than 75% the blood pressure in your body, that's probably going to be difficult to tolerate all these big changes during pregnancy. If your ventricle right, left, in the systemic position or not, if it doesn't function well, if it's kind of got a poor squeeze, you probably are going to have trouble increasing your cardiac output and growing this baby. If you're one of the patients with Marfan syndrome or one of the other aortopathies like Loeys-Dietz syndrome, your aorta is fragile and it might not like all this stress during pregnancy. You should really be counseled closely about whether it's safe on your aorta to have a pregnancy. And this is kind of a low cutoff. I put it in there as you may at 40 millimeters of your aorta be able to still have a pregnancy safely, but this is where you need to really be thinking. And then valve problems that are tight. So then you might say, what's the risk to my baby of this pregnancy? You've talked about my risk a lot, but am I going to have a healthy baby if I go through this? And the truth is, unfortunately, that moms with congenital heart disease do carry an increased risk of miscarriage early or even later in the pregnancy for the baby. Babies are at risk of being born early compared to the general population and being born small. And there is an increased risk of congenital heart defects, and that risk varies depending on what your condition is and whether your partner has congenital heart disease. So often we're sitting in the office and we're just talking to mom, and they're like, oh, well, you have this, so your risk is 3%, and then we find out dad also has tetralogy. Well, that changes the game. So we have to understand both parents play a role in the risk of a defect. And then it matters if you have a genetic condition that we can follow how high your risk is. So during pregnancy, things that are going to impact whether baby's born early are whether you can stay in rhythm. If you have a heart rhythm problem like AFib, aflutter, atrial tachycardia, that actually affects baby and will increase the risk that baby's born early. If your oxygen saturation is not normal, it's hard to grow a new human if you can't deliver oxygen down there. So that's going to impact baby's size and whether they're born early. If you smoke, that's true if you have congenital heart disease or not, that adversely affects baby. So smoking is a bad risk factor. And again, just like the general population, the older we get, the more likely we're going to have a complication with baby. So big question, do I need a C-section? For the most part, the answer is no. I would prefer that you not have a C-section. C-section is a major surgery. It doubles the estimated blood loss that you're going to experience during delivery. So most women don't need a C-section. I prefer you not to, unless you have an obstetrical reason for a C-section, like any other mom, your baby's breech or baby's in trouble, we certainly want to do it then. If you are one of these moms with a heart valve and you're taking warfarin, or you have another reason to be on warfarin and you go into labor without making that transition to another blood thinner, well, baby's anticoagulated, so we're going to have a C-section so baby's head doesn't get squished. If your aorta is really fragile, we're worried that you could have an aortic complication. Some doctors are going to recommend a C-section, not all. If you are not doing well, you're having a lot of trouble with heart failure, you can't breathe, your lungs have fluid in them, we're going to probably try to deliver this baby fast and you might need a C-section. And then depending on the physicians that you talk to, a mom who's decided to proceed with pregnancy who has high lung pressures, many centers will say we should control that delivery with a C-section. Not all, but those are the ones that we would consider it. So finally, does pregnancy alter my long-term health? Well, the jury's out on that, and we don't really know what happens 10, 20 years down the road after you've had this hemodynamic challenge to your heart condition. Right now, we don't have any strong data that we alter outcomes significantly with a pregnancy. You might hear some doctors say, oh, I think if you had a biologic valve, like your daughter has the porcine valve, that makes it wear out faster. That's probably not true when we look now at good studies, but we don't really know all the long-term consequences. So that's why you've got to stay in care with your adult congenital heart disease team even after pregnancy. But the good news is most moms can have a healthy pregnancy with some help and intervention from their team.